and elbasvir in hepatitis C genotype 1, 4, and 6 infected patients with HIV co-infection, the phase 3 C-EDGE co-infection study.
Thank you, Curtis. Ladies and gentlemen, it's a pleasure to be here and present the final SVR12 results of the phase 3 study, the C-EDGE in co-infection. This study is really looking at the combination of the HCV NS3/4A inhibitor grazoprevir, 100 milligram, which is dosed in a fixed dose combination with the NS5A inhibitor elbasvir, 50 milligrams. It has broad genotypic activity, retains activity against most clinically relevant RAFs, and is available as a once daily regimen. Now, you've heard from all the speakers about the tremendous impact HIV has on the course of hepatitis C. Let's just remind you that even in the setting of controlled HIV replication, there's still a high risk of hepatic decompensation. That underlines why there is a prioritization in guidelines for treating these patients. Now, the aim of the current phase 3 study was to evaluate safety and efficacy and tolerability of this new regimen as a fixed dose combination in patients with co-infection. The trial design is very simple. 12 weeks of the fixed dose combination, then 12 weeks of follow-up. The primary endpoint was SVR12. And patients were included if they were treatment naive for hepatitis C and had either a genotype 1, 4, or 6 infection. It was able to enroll patients with cirrhosis. With regard to their HIV information, it's important to note that they could be naive to antiviral therapy if the CD4 count was above 500, but the viral load below 50,000 copies. And for those who were on therapy, they had to be on the same therapy for 8 weeks and had a CD4 count above 200 and suppressed HIV viral load. If we have a look at the baseline characteristics, you can see the mean age was 48 years. Majority of patients were male. There was a fair amount of patients who were Black or African American. You can see that the majority of patients included were genotype 1A, 66%. Rest was really genotype 1B, 20%. We do have a fair fraction of genotype 4 patients, an N of 28, but only 2 patients with genotype 6, so that sort of limits our interpretation of that particular genotype. Most of the patient had a high viral load, which is the hallmark of co-infection, 60% of viral load above 800,000, and there was at least a fair amount of individuals with cirrhosis at baseline of 16%, was determined by various measures, either FibroScan, biopsy, or lab values. IL-28B CC genotype distribution was only 35% depicted a favorable CC genotype. Looking at the background antiviral therapy, you can really see that the majority of patients enrolled were on stable HIV treatment, 96%. Very few were naive. And you can see that the average CD4 count was really high with 613. If you look at the backbone, it was either a bacavir or tenofovir containing regimen, so it gives us a look at both new combinations. And the third agent was really based on the inclusion criteria. And remember, there are some interactions with the protease inhibitor, grazoprevir, and so the third agent was either raltegravir, which was the leading used agent with 51%, or dolutegravir, so I think this is also one of the first trials with quite some information on that as a third agent, and rilpivirine. Here is the main outcome of the trial, looking at the SVR12 results, and you can see, if you look at the full analysis set, that overall 96.3% of patients achieved SVR, which is clearly quite impressive. Looking at the relapses, you can see that overall 5 relapses occurred. If you then look at the genotype 1 subtypes, you can see that 1 and B numerically did quite as well, but relapses were only noted in the genotype 1A, 4, and none in the genotype 1B. There was 1 discontinuation early on in the genotype 1B patient due to a protocol violation, and so that counted as virological failure. The genotype 4, there was also 1 relapse. You will also note in the very bottom of this slide that there were 2 reinfections, and we'll come to that in a minute. Now, in a force plot analysis, we looked were there any baseline predictors, host or other demographics which might have an impact on SVR, and you will see that nothing really pops out as being particularly impactful. There are obviously wider confidence intervals when the numbers become small, so note that, and clearly we would need larger patient numbers, but clearly nothing struck out as being significantly associated with a higher or lower SVR rate, and the same holds true for the corresponding HIV regimen the patient was on, whether that referred to the nuke backbone or the third agent. As mentioned before, 5 patients relapsed, all were non-cirrhotic, 4, as outlined before were genotype 1A, one was genotype 4, and the 3 of those 4 were on a tenofovir-based regimen, 1 on abacavir. And of those 2 patients who were reinfected, 1 had a genotype 1A at enrollment and then ended up at follow-up week 12 to have a genotype 3 infection. And then 1B also turned up to have a genotype 3 infection at follow-up week 12, suggestive of reinfection. So these patients were classified as failure for analysis, but further sequencing and phylogenetic data was consistent with post-treatment reinfection. Now, having a closer look at the patients who failed in the trial, you will see the 5 relapses we identified. As mentioned before, 4 were in the 1A group, and you can see that 2 of the patients already had NS5A RAFs persistent at baseline, and then developed NS3 and additional NS5A mutations upon virological failure. There was 1 patient who had wild type at the beginning of the trial and then developed NS5A mutation at failure, and there was 1 patient who was wild type at the beginning of the trial and also at reappearance of viral load, and then there was 1 patient who also was wild type and then developed another NS5A mutation. Of those patients who were reinfected, none of the patient came up with resistant-associated variants. Looking at the phylogenetic tree analysis for reinfection, for the first individual, you can see that the viral strain identified at day 1 is completely different and very distinct from the viral isolate detected at failure, which is suggestive, as obviously there's also a genotype difference between the 2 variants. The same holds true for the individual number 2, where you also see the distinction between day 1 and at failure appearance of the new viral strain. Looking at the adverse events, obviously, other than efficacy, the other thing we're interested in is how safe are these new regimens, and you can see that the amount of serious adverse events was low. There were very few patients with adverse events, but let me first really point out what I think is probably the most important in these trials is that nobody discontinued because of a drug-associated adverse event, which is important and underlines the tolerability of these new all-oral agents. Of the common adverse events, which were not necessarily, though, associated with drug intake, were fatigue, headache, and nausea. You can see from the lab abnormality very few changes, 2 patients with a liver enzyme increase, and no changes with regard to creatinine. 2 patients received who were receiving antiviral therapy for HIV, experienced transient HIV viremia, so they were blipping. Both patients subsequently, though, achieved undetectable HIV RNA with additional compliance education and without changing the ARV regimen. There were no notable changes in CD4 cells from baseline compared to treatment week 12. So in conclusion, I think I was able to show you that high rates of sustained virologic response were achieved in patients with genotype 1, 4, and 6, and HIV co-infection receiving the all-door fixed-dose combination of grazoprevir elbasvir. I don't know whether I mentioned that, so let me say it here. The 2 patients with 6 cleared infection, but again, these are only 2 patients. There were comparable response rates across all patient subgroups, including Black African Americans. There were comparable response rates in cirrhotic and non-cirrhotic patients. Remember, 17% upon inclusion were classified as cirrhotic, and the regimen overall was well tolerated with very few serious adverse events and no discontinuation because of drug-related adverse events. So in summary, the low rate of adverse events, the once-day administration, clearly makes this a suitable regimen for patients with HIV and hepatitis C co-infection. If you're interested in the study and to see more background information and additional analysis, I welcome you to go to the Lancet website where this study is already available since the 9th of July as an online publication. And I would like to really acknowledge and thank all the patients, their families, and the investigators who participate in this study. You see all the different investigators listed, and it's really great thank to pull the data all together to make this final presentation possible. Let me also thank Merck, which funded this study and supported the medical writing by Apothecom. Thank you very much.
Great, thank you very much, Jürgen. So I'll get us started. Now, you mentioned that there was 2 patients who were reinfected after achieving a sustained virologic response. So I'll just ask you to speculate as to whether what lessons can we learn about treating patients for hepatitis C who are still actively participating at high-risk activities?
Yeah, so I think that it's an important, very important message for the field, because obviously we saw the same thing in the analysis David presented. There were also 2 reinfections. That tells us that DAAs is not the solution for everything, so you can cure your patient, but he remains at risk of reinfection if risk factor which led to the infection primarily remains unchanged. And that really tells us that we have to implement other strategies, and that clearly is in the setting of IV drug use. I think we have great proof for the effectiveness of harm reduction programs. I think we're struggling much more with the reinfections in the HIV positive MSM who sexually acquire their hepatitis C, and it seems to be much more difficult to reach a harm reduction profile there, although I think we also have to be well aware that increased sharing of needles for use of drugs in a sexual context are also a contributing factor for this epidemic, and because the whole IV drug harm reduction measures simply do not seem to reach this group in the same way, I think we will have to make more key population targeted interventions readily available.
Great, thanks. Microphone 3.
In those patients who failed therapy, how did you treat them?
Yeah, so far there is no retreatment strategy for these patients. I think this is a great question, because indeed the question is, what do we do with patients who end up with resistance? And you may have noted that at least one of the patients had resistance against the protease inhibitor and the NS5A. And so that really makes it very complicated, because the question is, with regard to the cross-resistance, what other treatment options do you have? Obviously, the drug which is unaltered in its activity would be sofosbuvir. Clearly, you would add ribavirin in this. And what I've learned is that, first of all, we really need more resistance testing in patients who fail, and that actually there is some retreatment data, for example, with sofosbuvir ledipasvir, which points to the fact that it's really depends on which exact mutation you have. So if you have the L93, for example, your response rate is really clearly diminished, whereas if you have some others, it may be much better, and it's also a question of the number of RAFs you have in the NS5A region. David has presented a paper at EASL looking at the persistence of NS5A mutations, and unfortunately, in contrast to the protease inhibitor mutations, which seem to disappear over time faster with genotype 1b than with 1a, these variants seem to persist over 2 years. So there's little hope that we're actually going to lose these NS5 inhibitor related or associated mutations, and they will have an impact. So I think this is a clear quest, and I think also in consideration of the patients who participate in these trials, we'll have to develop strategies. Hopefully some of the more pangenotypic drugs which are in development and also seem to exert activity, even the presence of some mutations, may be an